Hello everyone, today we'll be talking about congenital syphilis. So congenital syphilis, this basically refers to the transmission of maternal infection to the fetus, leading to congenital syphilis, okay? So overall, the risk of transplacental infection of the fetus is about 60 to 80%, and the likelihood is increased during the second half of the pregnancy. Untreated primary or secondary syphilis in the mother usually is transmitted, but latent or tertiary syphilis is transmitted in only about 20% of cases. And untreated syphilis in pregnancy is also associated with a significant risk of stillbirth and neonatal death. Okay, that's how screening for syphilis during pregnancy is routinely done. That is basically to avoid congenital syphilis. In infected neonates, manifestations of syphilis are classified as, so they're classified as early congenital, which is birth through age of 2 years, and this late congenital, which is after the age of 2 years. So symptoms and signs of congenital syphilis. Many patients are asymptomatic and the infection may remain clinically silent throughout their life. So when we talk about early congenital syphilis, it commonly manifests during the first 3 months of life. And manifestations include characteristic vesiculobulbous bullous eruptions or a macular copper-colored rash on the palms and soles and papular lesions around the nose and mouth and in the diaper area, as well as petechial lesions. Generalized lymphadenopathy and hepatosplenomegaly often occur. The infant may fail to thrive and have a characteristic mucopurulent or blood-stained nasal discharge causing sniffles. A few infants develop meningitis, choroiditis, hydrocephalus or seizures, and others may be actually intellectually disabled. So within the first 8 months of life, osteochondritis or chondroepiphysitis, especially of the long bones and ribs, may cause pseudoparalysis of the limbs, with characteristic changes in the bone that we are going to discuss later. So basically what we said is there will be skin lesions, there will be generalized lymphadenopathy and hepatosplenomegaly. Infant will have failure to thrive and a bloodstained nasal discharge. Some may develop meningitis, choroiditis, hydrocephalus or seizures, and they may have intellectual disability. Then others may develop bone problems that can lead to pseudoparalysis of the limbs. Now, when we talk about late congenital syphilis, it typically manifests after 2 years of life, and it causes comatose ulcers that tend to involve the nose, septum, and hard palate and periosteal lesions that result in sebaceous embossing of the frontal and parietal bones. The neurosyphilis is usually asymptomatic, but juvenile paralysis and TEPS may develop. Then they have optic atrophy, and sometimes it may also lead to blindness. Then there's interstitial keratitis, which is the most common eye lesion, and it frequently recurs, often resulting in corneal scarring. And sensorineural deafness, which is often progressive, it may appear at any age. Then Hutchinson incisors, or you can say Hutchinson teeth, mulberry molars, perioral fissures, and maldevelopment of the maxilla resulting in bulldog faces are characteristic of infrequent sequelae. So when we talk about congenital syphilis, so in early congenital syphilis, which is the first 2 years, we said hepatosplenomegaly is seen, snuffles, syphilitic rhinitis, then Hutchinson, then vesicular and bullous eruptions. Are you able to see this? Then there's bilateral destruction of medial tibial metaphysis, which is also known as the Wimberger sign. Then in the late, we usually get the Hutchinson triad, which is Hutchinson incisors, interstitial keratitis, which is very common and may lead to corneal scarring, and sensorineural deafness. So it's basically a diagram showing congenital syphilis features. So hydrophysalis, nasal discharge, hepatomegaly, rash, osteitis. So this is the same Hutchinson triad we discussed. So Hutchinson's teeth, which is bag-shaped notched incisors. Are you able to see this? then interstitial keratitis, and age nerve palsy, which is the sensorineural deafness, okay? So diagnosis of congenital syphilis. So early congenital syphilis, it's by clinical evaluation, depth field microscopy of the lesions, placenta or umbilical cord, serologic testing of mother and neonate, possibly CSF analysis. Then late congenital syphilis, clinical evaluation, serologic testing of the mother and child. So remember I said there's one manifestations of congenital syphilis. So it can cause many different abnormalities and on long bone excess that include periosteal reaction. Be able to see it's not really a clear line. There's some fuzzy appearance here and here. That's the periosteal reaction. Then there's diffuse or localized osteitis, metaphysitis, and the osteitis is sometimes described as diffuse moth-eaten changes of the shaft. Okay. So we've talked about the follow-up. Now we've talked about the diagnosis. So how do we follow up these children? So all seropositive infants and those whose mothers were seropositive should have a VDRL or RPI titers every 2 to 3 months until the test is non-reactive or the titer has decreased fourfold. Ideally, this was supposed to be after treatment. I don't know why this is here right now. So all this that we will do follow up after treatment, okay? Then in uninfected and successfully treated infants, we do non-treponemal antibody titers. They're usually non-reactive by 6 months. Then if the RL or RPR remain reactive by 6 to 12 months of age or titers increase, the infant should be re-evaluated, including lumbar puncture for CSF analysis and complete blood count with platelet counts, long bone X-rays, and other tests as clinically indicated. So this basically depends on how is the patient presenting. So treatment of congenital syphilis is parenteral penicillin. So how do we treat pregnant women with syphilis? So pregnant women in the early stages of syphilis, they receive bendazustine penicillin G, which is 2.4 million units IM in a single dose. And for later stages of syphilis or neurosyphilis, the appropriate regimen for non-pregnant patients should be followed. Then for early congenital syphilis, this is according to CDC guidelines, we give aqueous crystalline penicillin G 50,000 units per kg IV every 12 hours for the first 7 days of life and every 8 hours thereafter for a total of 10 days, or procaine penicillin G 50,000 units per kg IM once a day for 10 days. So a summary, basically congenital syphilis is a multi-system condition that is caused by treponema pallidum and is transmitted to the fetus via the placenta. So early signs are characteristic skin lesions, lymphadenopathy, hepatosplenomegaly, failure to thrive, bloodstained nasal discharge, perioral fissures, meningitis, choroiditis, hydrocephalus, seizures, intellectual disability, osteochondritis, and pseudoparalysis. And later signs are gummatous ulcers, periosteal lesions, paralysis, jabs, optic atrophy, interstitial keratitis, sensorineural deafness, and dental deformities. Diagnosis is clinical and it's confirmed by microscopy or serology, and treatment is by penicillin. So how can we prevent congenital syphilis? So pregnant women should be routinely tested for syphilis in the first trimester and retested if they acquire other STDs during pregnancy. In 99% of cases, adequate treatment during pregnancy cures both the mother and fetus. However, in some cases, syphilis treatment late in pregnancy it eliminates the infection, but not signs of syphilis that appear at birth. So infection will be eliminated, but signs will still be present. Treatment of the mother less than 4 weeks before delivery may not eradicate fetal infection. So the only time when fetal infection will be eradicated is if treatment was more than 4 weeks before the delivery. So these were my references, which is CDC and MSD manuals. Thank you.